back. Let's start with primary atypical pneumonia. In primary atypical pneumonia, as we can see, now what are the features? It's caused by atypical agent, that is Mycoplasma pneumonia, a small free living organism. Other times, it can be caused by other means there are three agents which are coming under this atypical variety. Number one was Mycoplasma pneumonia, number two chlamydia, number three Legionella. So this is also transmitted by droplet infection. A very specific feature is that it occurs in epidemics, chiefly in winter, among children in overcrowded living. Then it's uncommon in children below 4 years of age. Okay. Then incubation period is quite long, 12 to 14 days. The onset is insidious or abrupt. Initial symptoms are malaise, headache, fever, sore throat, cough, myalgia. Cough is dry at first, but later associated with a mucoid expectoration, which may be blood steeped. Dyspnea is unusual. That means usually the child is very comfortable, means dyspnea will not be there. Other features like fever, headache, malaise, cough may be there, but dyspnea is unusual. So there are very few physical signs except mild pharyngeal congestion or cervical lymphadenopathy and a few crepitations. When you will do the examination, the child will be fine, no dyspnea, no toxic looking. Very few signs like mild pharyngeal congestion, cervical lymphadenopathy, and a few crepitations. Cold agglutinins are elevated in around 50% cases. Now, X-ray findings are more important than the physical findings. You will see infiltrates involving one lobe. Usually, the lower lobe is involved. Poorly defined hazy or fluffy exudates radiate from the hilar regions, occasionally with enlarged hilar lymph nodes, and you may even find pleural effusion. It's difficult to differentiate mycoplasma from viral or rickettsial pneumonia. So, how will we do the diagnosis? With the detection of IgM antibody by ELISA during the acute stage, and IgG antibodies are present after 1 week. This mycoplasma may be recovered from the pharynx, from the sputum, and the diagnosis is confirmed with the help of PCR. How do we treat? We give macrolides, that is erythromycin, azithromycin, or clarithromycin. If not macrolides, you can give tetracyclines for a again small period, 7 days to 10 days. So let's see if anything has been left in this not covered. The various agents we discussed, 4 years of age, it occurs after 4 years of age. Then primary involves the interstitial tissue. Okay, so interstitial tissue, this also we discussed. Round cell infiltration. Okay, round cell infiltration. Alveolar septae are edematous. Okay, and the mucosa of the bronchioles is inflamed and may ulcerate. So the septa are edematous and the bronchioles, the mucosa of the bronchioles is inflamed. So septa are also edematous and the mucosa of the bronchioles is inflamed. Obstruction of the terminal bronchioles causes emphysema and atelectasis. So sometimes obstruction may cause emphysema and atelectasis. Pleura, as we discussed, may be involved. So pleural effusion is there. Clinically, incubation period is long. Initially dry cough, all that. Blood steeped cough may be there. Dyspnea is unusual. Physical signs are mild. Sometimes hemolytic anemia may be seen. X-ray findings more extensive. Hazy, fluffy exudates radiating from hilar. All this is done. Now diagnosis, it's difficult to differentiate from this. Okay, cold agglutinins, yes. Culture from pharynx, sputum, ELISA, PCR. Okay, IgM and IgG, these two factors we discussed. Treatment, macrolides or tetracyclines. Okay. Now we will discuss about this chlamydia, nothing. Clinical features include spasmodic cough and may be seen in young infants, that is early neonatal period. Sometimes conjunctivitis may be present. Now, pneumonia due to gram-negative organisms. In this, what are the main three prime ones? E. coli, Klebsiella, and Pseudomonas. They affect the small children less than 2 months of age, means all the weak ones, very small age, or malnutrition, low birth weight, low immunity, etc. Pseudomonas may colonize airways with patients of cystic fibrosis and may cause recurrent exacerbation. So it can cause recurrent disease and may be associated with cystic fibrosis. Onset is gradual, but later conditions become quite serious. Then the signs of consolidation are minimal. Constitutional symptoms are more prominent than any respiratory distress. On a radiograph, multiple areas of consolidation. E. coli and Klebsiella may produce again the same pneumatoceles as was seen in staph. So how do we treat IV cefotaxime or ceftriaxone plus minus aminoglycoside for 10 to 14 days? If it is pseudomonas, the drug of choice is ceftazidime. So let's see if we missed anything. Okay, this is all we did. The clinical features we discussed, yes. Signs of consolidation are minimal. X-ray findings, unilateral or bilateral consolidation. Pneumatocele formation, intravenous use of third generation cephalosporin, ceftazidime or piperacillin tazobactam are effective for pseudomonas. So ceftazidime or piperacillin tazobactam for pseudomonas. Okay, so let's end this lecture here. Thanks a lot for watching.